Good morning, everyone. Afternoon for others. Thank you all so very much for joining us for the Impacts Update, our community webinar. We will get started in about 4 to 5 minutes to give everyone a chance to log in here. Thank you all so very much, and I hope you don't have a problem with the short wait. We'll get started shortly. Just so folks know, just we want to remind everyone when you're not speaking to just make sure that your microphones are muted. Everyone is joining us is muted currently. This will be a recorded session, as Michael just dropped in the chat. So just know that if you are not speaking, just make sure to have your mic muted. Thank you. And again, we'll get started in about 4 minutes. Thank you all for joining us. My name is Max Boykin, the facilitator for this Mpox update, a community webinar hosted by PrEP4All. And with that, we're going to get started in a couple more minutes, giving everyone a chance to log on here. Thank you all so very much for joining us. We will get started shortly. If this is a recorded session, so if you are not speaking, please just keep your mic muted. We will have a chance for a question at the end of this presentation for about 15 minutes, and we want to make sure that you can come off mute then. But thank you all so very much for joining us, and we'll get started in a couple minutes. Hello, everyone. Thank you all so very much for joining us. And I see that we have everyone on. My name is Max Boykin. I use he, him, and pronouns. I am the manager of the Save HIV funding campaign, which a Prep for All is a huge, important part of. And I am based out of Atlanta, Georgia. I am going to ask everyone, if you don't mind, to introduce yourselves in the chat so just we know who's also here on the call. That means put your name, pronouns, organization or coalition, affiliation along with where you are in the world. I think that is an absolutely wonderful thing, just so we can see who is all joined us on this call. Again, my name is Max Boykin. I am the manager of the Save HIV Funding Campaign, and this is an Mpox update, a community webinar by PrEP4All. We have some amazing speakers for everyone to be able to get a chance to hear from. These are some absolute like wonderful folks who are really experts in the field, and we want to give them an opportunity to really speak more of on what they're seeing and also the update around like what we're seeing across the world. Um, with that, sorry, I'm slight technical difficulties. Um, I want to introduce Monica Gandhi, a professor of medicine at UCSF, University of California, San Francisco. And I want to allow for her to introduce herself, but also answer this first question that we have. Many of us were affected by the Mpox outbreak in the United States in 2022. As providers, allies, and advocates, and people who acquired Mpox, can you start us off with a grounding in what's happened during this public health emergency after it ended and up to the present moment? And then, when particularly interested in the state of Mpox transmission around the globe and in the United States, and what do increased warnings about Clade 1B mean for community members?
Okay, well, thank you so much for having me. Can you hear me okay, Max?
Yes, we can.
Okay, great. I'm just gonna actually start with a background and then we'll go into Andy's presentation for the what's currently happening and then Joe's presentation really for the epidemiology in the United States and everything that's happening around the country. Just in terms of a background of Mpox, where did this come from? It actually, when we divide viruses, just thinking about viruses, we divide them into DNA viruses, RNA viruses, and then some that are both. So retroviruses are actually both. They start with RNA and go into DNA. RNA viruses, the most famous recent one was SARS-CoV-2, but Mpox is actually a DNA virus, and it has some very famous relatives. Its relatives are smallpox, which was called variola virus. It's now eradicated. Vaccinia, which helped us make smallpox vaccine. Cowpox virus also helped with the vaccine, and boreal pox virus. So famous cousins. And the way that it was first described in 1958. There were actually two outbreaks in monkeys that were used for research, but monkeys are not major carriers of disease, and this name was eliminated in 2022. It is closely related to smallpox, which is why we use the smallpox vaccine actually for mass Mpox vaccination. And remember, smallpox was an incredible success of public health efforts that it was eradicated in 1980 worldwide, 1970 here in the US. And that was all really because of either natural infection causing immunity for life, and better yet, the vaccine, which was really effective. So we already were seeing, even before all the attention got paid to Mpox in 2022 with a big global outbreak, there were already outbreaks occurring in Central and West Africa. They weren't getting the attention that they needed at that time, but it was happening. There were outbreaks of this particular infection. And then we got into a big global outbreak, which I'll talk about next. And that's what raised the world's attention to Mpox. The ch name was changed to Mpox on November 18th, 2022 by the WHO during the global outbreak, and that's appropriate to use that term. And actually, variants had been named after specific regions in Central and West Africa. We don't tend not to name or organisms from the regions where they're located because they're everywhere. And so they were renamed into the words clades 1 and 2, which Andy's really going to get into when he talks about what's happening now. Now, in the United States, Mpox was really rare. It actually was just prior to the big global outbreak of 2022. We'd see it if there was a traveler that was returning from an endemic region in Central and West Africa. There was a kind of bizarre outbreak in 2003 where there were animals, actually specifically animals that had been imported from Ghana, and they pet prairie dogs ended up interacting with these animals, and people had their pets with their prairie dogs, and they ended up having that out. We ended up having in the Midwest 71 people get infected from interacting with their pet prairie dogs. But that's in retrospect. It seemed like there was nothing that, these endemic outbreaks seemed to be related to animal exposures, and they had always been called really related to rodent exposures. But in retrospect, when we look back, there was likely a sexual transmission occurring of Mpox in West and Central Africa. So, what happened in 2022? It was a big surprise. It was also as COVID was winding down, so there was just a lot happening. And the first case of a non-endemic, meaning not in West and Central Africa, case of Mpox was reported to the WHO on May 2nd, 2022. Very quickly, cases were seen around Europe, Canada, Australia, US, Latin America, and the WHO declared a public health emergency of international concern 2 months later, on the 22nd of July, 2022. By the time we got to the end of that particular public health emergency, which the WHO declared over on May 11th, 2023, there had been 87,000 cases around the planet. And again, in non-endemic regions, this is now something that is there and out there, and 140 deaths in that outbreak. And there was a declaration that, quote, the public health emergency was over, likely without paying attention that the endemic regions of Africa had not received any vaccine. So, what were the symptoms in the 2022 global outbreak? It was actually really seemed to be most closely related to occurring in men who have sex with men. At least the first description in the New England Journal of this outbreak, 98% were gay or bisexual men. First white, but certainly went into racial and ethnic minorities in the United States very quickly and into the South. There were really mostly skin lesions, really thinking about that this was mainly sexual transmission. Lots of regions anatomically in the anus, genital regions really uncomfortable, and it could be singular or multiple. And just like pox viruses always do, have a variation of manifestations. Start out with different, the pox can look different, flat blisters, and then go on to crusted lesions. That's what these types of viruses do. And there were some fevers and lethargy, but not as much as had been described in the endemic outbreaks in West and Central Africa. And it did seem that there was a proclivity for people living with HIV, and we'll talk about that in a minute. So these were the manifestations of lesions, right? Going from vesicles to flat lesions to over the crusting. This is, they were seen in the mouth, they were seen in the genital regions, really, really, really could be very painful. And so then there was a second description in the CDC MMWR, and by this time, the United States cases were all over 43 states, Puerto Rico, again, 99% men, 94% same-sex activity, was really all in different minority populations, wasn't just white, started maybe white more. And then really interesting overlap, an important overlap with HIV. This is the small first time we've seen an orthopox virus and HIV exist at the same time, right? Because smallpox got eliminated in the United States in 1970, and we saw our first cases in 1981. So this idea that there in some way HIV predisposes to the orthopox virus came up at this point because there was more people living with HIV, and they did seem to have more severe manifestations in other reports. There was also a lot of overlapping STDs. So other STDs that cause ulcerative genital disease like herpes or syphilis. And it seemed that people with HIV, who had a low CD4 cell count, could have more severe disease, and actually it's now classified as an opportunistic infection in HIV, that the Mpox lesions. So everyone was debating this. The question of calling it an STD can certainly be called an STD, even if it's not just sexually transmitted. For example, herpes, syphilis, molluscum contagiosum, they all are infections that are mostly sexually transmitted, but also can be transmitted through close contact. Before we universally gloved, we would see herpetic whitlow all the time in providers if they touched a herpes lesion. So you can get, for example, contact to children and they can get Mpox, but the more predominant mode of transmission does seem to be sexual. So I will just mention a couple of other things and then we'll go on to what's going on right now. There is limited data in pregnancy, but it does seem that Mpox is not a good sort of infection to get during pregnancy. There has been reports of spontaneous pregnancy lost in stillbirth, so we want to be careful. We want to absolutely vaccinate people who can get pregnant. And then what about the vaccine? Well, we didn't have to invent a new vaccine, and that was really kind of great in terms of how quickly we could get the vaccine out. Of course, global vaccine inequity absolutely occurred, and we shouldn't have gotten just the vaccine out in high-income countries, but that's what happened. But the Jynneos vaccine, which is had already existed for control of smallpox vaccine, was very effective. Not the ACAM 2000 that has more side effects, but Jynneos was very effective for Mpox. And in fact, this is a nice paper from the CDC right after the public health emergency ended, that it really was very high rates of protection, at least against severe disease. And that's going to be the clue when we talk later. And this sounds like a familiar story, like COVID, that COVID vaccine can protect against severe disease because of its cellular related immunity, but lost its ability to protect against all infections because antibodies go down. And so this was a very effective vaccine against severe disease, but we'll talk later about does not prevent all infections. And two doses are really important. So when we're going to talk later about everyone getting their second dose, that's incredibly important. So that global health emergency was ended. And then just a year and 3 months later, a new public health emergency had to be declared by the WHO because we had, again, not given global vaccine equity, had not given West and Central Africa the vaccine, and two clades, which we had talked about before, one and two, were emerging, were there, and clade 2B was the one that was most common in the first global outbreak, but really clade 1 came up as being associated with this first outbreak that was identified in the DRC. So I'm going to stop to get into the epidemiology that Andy's going to tell us about. Just want to mention one other thing about treatment. We thought we had a treatment because in vitro, at least, and against smallpox, it looked like this particular antiviral called tecovirimat would have effectiveness against Mpox. So we were using it compassionate use. The CDC was giving it to people with severe Mpox during the 2022 3 outbreak. But unfortunately, the reason we do randomized clinical trials is to see if it works. And because of these big global outbreaks, we could do two randomized clinical trials, one in the DRC, and this is important because this was against clade 1, and tecovirimat did not show efficacy to prevent or make severe disease better. And in fact, actually, clade 1 people with clade 1 did do pretty well if they got right supportive care, and that will come up in Andy's presentation. And then a second trial in the United States, which is the STOMP trial, looked at tecovirimat in a randomized controlled way, also placebo versus tecovirimat. And tecovirimat did not work. It did not make symptom duration, number of lesions, anything better, unfortunately. So we do not have an antiviral right now that we can turn to for Mpox. So I will end there to get into what's happening right now.
Thank you so very much, Dr. Gandhi. That was absolutely like wonderful, and really giving us like the breakdown there. Next, um, I will pass it on over to Joe. Joe's a molecular
Yeah,
microbiologist.
Andy's gonna go next. We switched up the order. Sorry about that.
Okay, gotcha. So Andy, next is an advisor with the World Health Organization, Department of HIV, Tuberculosis, Hepatitis, and Sexually Transmitted Infections. He supported WHO's response to the multi-country mpox outbreak that started in 2022. Andy, you have a global view of the responses, especially in the context of HIV impacted communities. Where do we still have a robust response to mpox, and what do we now have gaps? What do we need to know about the tools that we have had at our disposal, and how has that changed since 2022?
Thank you so much, Max, and really appreciate this opportunity. Just to check, you can hear me okay and you can see the slides.
Yes, we can.
Fantastic. And thanks, Monica, for a really great kickoff. And I will, as Monica indicated, try and build a little on what's already been a really great and founding presentation, setting the scene for where we are today. But before I start, I would like to acknowledge two colleagues who are really the experts on mpox from WHO who are on this call as well. So really delighted to see both Rosamund Lewis, who's our mpox expert and lead, and Lennox Abanez, who's our surveillance and epi lead on mpox at the moment. They've both supported me in developing this presentation, and really good to see them online. And I'm sure that they will engage in the chat if they're able to stay for the duration of the webinar. So what I'd like to show now is really a little bit around, what's the last year been like? So Monica talked us through, particularly what had been happening in the States, what had happened in the first public health emergency of international concern. And she correctly identified the fact that a second public health emergency of international concern was declared in August last year. That one was also the emergency was lifted in September this year. But as we know, and as was clear from Monica's presentation, mpox circulation continues, of course, even outside of these periods that are defined as emergencies. So what you can see on this slide is, clearly we do in the last 12 months, we still see a really strong focus on the Africa region, where we've got multiple modes of transmission really dominating that outbreak or that ongoing mpox situation. But outside of Africa, we're still seeing the majority of cases being reported as clade 2B, which was the clade that was part of that first outbreak that was largely focusing on sexual transmission and MSM. But you see, it really is still affecting all WHO regions, including, of course, the Americas, where I think most of the people on this call are joining from today. Again, a little bit more about the clades. This image would have looked very different a few years ago. So what we can see here is quite an interesting evolution of what's happened between the various clades that have emerged, and I think they've all, and Rosamund will correct me if I'm wrong, they've all emerged from Africa. But then we've seen, as Monica was suggesting, some cases of isolated travel-related infection, sometimes leading to community infection, but the sustained infection from the 2022 multi-country outbreak was clade 2B. But many of those clade 2B countries, as you can see on this map now, or the ones that were really impacted by that outbreak, have also reported on other clades as well. Interestingly enough, if you can see that, I'm just moving my clade 1B, so the one that we're focusing on, I think pretty much today, it is unique to a number of African countries. So the current emergency that was largely focused in and around Central and Eastern Africa, and then expanded to neighboring countries, we haven't seen cases of any other clades reported in several of those countries. So that in itself, I think, is something worth reflecting on. But the main issue here is that there are multiple clades in circulation in most countries of the world where there is mpox, apart from the standout cases you can see on this map, including the newly affected countries in the Africa context. Again, building on Monica's slide, no surprises really that outside of Africa and across all regions, we're still seeing a largely male epidemic, a young male epidemic. So you can see the age-sex distribution on the right here. So it's largely men between the ages of 20 and 50. And very few women impacted. Of course, there are women impacted. We know that sexual transmission is not the only route of transmission for all clades of Mpox. But then the other case profile data you see on the left, and this is really looking at the year September 24 to September 25. Again, you can see where we have the data, of course, so this doesn't cover all of the cases, but where we have the data, we're talking about 87% have responded yes to self-identifying as gay or men who have sex with men. When we look at people living with HIV, again, as Monica was saying, 50%. And I would say perhaps one thing, Monica, that I would elaborate on from your presentation, I think the clinical outcomes for HIV are related to untreated HIV. They're not related to people living with HIV. So I think we do need to make that point. So people who have got an HIV diagnosis and are successfully on treatment should have similar outcomes to people who don't live with HIV. And then you can see the other data here, sexual transmission, high percentage here from the data available, so almost 90%. Again, so that this is interesting to see that even in the last year, we see a very similar, outside of Africa, a dynamic to what we saw during that first public health emergency of international concern. Now, bringing us up to date, so the cases that you've been rightly concerned about in the US context, and I think has really prompted this webinar, are not unique to the United States. We've also seen multiple cases that are largely suspected to be linked to sexual transmission and linked to MSM, although we don't have full data on all of these, are from clade 1B, because there's ongoing clade 2B reporting consistently across all countries. But isolating this to clade 1B, we can see that we're seeing a number of countries now where there's community transmission happening that's not linked to travel history. And this is really important for us as we think about strategy and what to do next. So if we do have community transmission happening quite widely, what should communities be thinking about? Do we need to be doing anything differently compared to the first public health emergency of international concern, etc. So really great that we have this webinar today. We're also hoping to publish some updated disease outbreak news information either on Friday or early next week, which will update some of the issues around the latest data from Europe and elsewhere. For example, we know that there are some cases linked to sex venues in Europe, which are likely to be of interest, but we need to wait for that report to come out before we can share more on that. Finally, I'd just like to remind colleagues of a few external products that are provided through WHO. I just mentioned the disease outbreak news, so please keep an eye out for that. I can ping Jeremiah and colleagues as soon as that comes out, so you can get that into your networks if that's interesting. And then we've got some good situation reports and epi updates online as well as public health advice, which I think still remains very critical for this audience. So we've got public health advice for gay, bisexual, and other men who have sex with men. We've got public health advice that's specifically focused on sex on premises venues and events, and also public health advice for sex workers. And all of this, we've tried, and we are WHO. Often when this kind of advice is translated for community level, there is an adaptation that makes it more easily accessible to communities. But nevertheless, we've really tried to be pragmatic with our advice and make sure that it's written in languages that can be that can be well understood. Final slide is really just leaving us with some considerations. Monica also talked about the ongoing links to HIV and STIs, and we have standing recommendations from the first, fake, and indeed all of our work around how we should be thinking about Mpox particularly outside of Africa, where you've got a much more complex situation with modes of transmission. And the key thing here is where there is clear sexual transmission happening, really integrate Mpox detection, prevention, care, and research within HIV and STI prevention and control programs and related health services. So this makes a lot of sense. You know, my department worked closely with the Mpox team and the emergencies team for some years, and we've really tried to place emphasis on this. But of course, we're all living the realities of this year. And the funding disruptions don't just impact low and middle income countries. I think they're impacting, you know, the whole world, frankly. And so I think there are big questions about what does this mean when we even know that HIV prevention programming and STI testing, for example, those programs are under financial pressure. And the final point I'll leave you with is just to say that WHO convenes a group called SAGE, the Strategic Advisory Group of Experts on Immunization. They will be reviewing the latest data, excuse me, let me go back, on Mpox vaccine, really to really explore the duration of immunity and protection offered by vaccines and see whether there might be any recommendations possible with the evidence available around booster doses. But as Monica said, the key message for now is if you've only had one dose, try and get yourself your second dose so that you complete that package. And finally, a big thanks to Rosamond and Lennox and other colleagues, Grace and Eva and others from WHO in helping me prepare this presentation. Thank you.
Thank you so very much, Dr. Seal. That was actually absolutely necessary information and understanding also the impacts on the global scale. Next up, we have Joe. Joseph Osmondson is a molecular biologist, writer, and organizer. He is a clinical associate professor of biology at NYU. Now that we've heard from the global scale from Andy and also understanding Monica's laid the foundation for us around impacts in the recent past. Can you, Joe, let us and tell us more of like what's happening right now, what you're seeing, and how folks can respond?
Yeah, thank you so much, Max and Monica and Andy and Jeremiah and everyone for setting this up. This really comes from questions we were getting directly from community in response to Mpox sort of popping back up into the news, initially with the outbreak largely focused in Central Africa, DRC and around, and now with the Clade 1b cases that have been found in Los Angeles. So this has kind of been a difficult story to talk about for the last couple of years because, well, there was this huge expanse of information and knowledge about Mpox in 2022 when we were hitting hundreds of cases a week across the US. Mpox has not gone away, although attention has gone away in the US. And I've talked to a lot of people who have had Mpox in 2023 through 2025, and it's actually a bit more lonely because it's sort of fallen away from public consciousness. Mpox has not gone away. And this was our worry in 2022 that if we did not act sort of very aggressively with vaccination early, the Mpox would become sort of a routine STI, like syphilis, like gonorrhea, that people deal with as a part of their sort of day-to-day lives of sexual wellness. And this is indeed exactly what we've seen. So since 2022, when there were large peaks of cases of hundreds a week across the US, Mpox has gone low, but not gone. So many places continue reporting multiple cases a week. Largely again here in gay urban centers, New York, Chicago, Seattle, San Francisco. And again, sticking very close, most of these cases to queer sexual networks, mostly men who have sex with men. So we've been getting a lot of questions because there's been news from New York, from LA, from Chicago, and Seattle about an uptick this summer in Mpox cases. And indeed, New York, Chicago, LA, and Seattle have all put out, the public health people there have all put out announcements about these increases in cases. So New York is up to about 20 cases a week now. I'm going to show you some graphs to sort of contextualize. None of this is anywhere near to the level of what we saw in 2022. So this is a huge message, right? 2022 was a public health emergency. The scale of the epidemic was really large, and we are not back there. So there were huge changes in sexual behavior in 2022 as a response to this large Mpox outbreak. The scale right now is an order of magnitude lower at least. So LA, 10 cases a week, Chicago, 15 cases a week. One very worrying data point that we just got was from Seattle that reported almost 50 cases in September alone. And their 2022 peak was 200 cases. So that actually is, sort of back on the scale of the 2022 outbreak. And it's really hard to pinpoint why that might be. Again, just to sort of contextualize this data, if you look just at the 2025 data from New York, you can really notice that we have an obvious uptick in cases. We were seeing fewer than 5 cases a week early in the year, and by the end of the year, we're seeing about 20 cases a week. Now, to show you data from Chicago to contextualize, if you compare this to 2022, this peak that we're seeing in many cities in late 2025, it's not the same epidemic, right? So this is not this public health emergency where we're seeing a ton of disease, okay? If you think about this in terms of the epidemiology, it's a little bit hard to conceptualize how cases are sort of ticking along, but not going up and also not going down to zero. So a community research team that I'm a part of looked at Mpox sequences to try to understand how this is occurring. And this is the only piece of data that I'm going to show you. Basically, on the x-axis here, you have time starting in 2022 and ending end of 2024. And this is data from LA County. So each new circle is a time that we find that the virus is introduced into LA County. And then the length of the line is the length of time that that virus actually transmits locally within LA County. So what we see in this data analysis is that you have a combination of new viral sequences entering a large urban center like Los Angeles or New York, spreading locally for a bit of time and then dying out. But at the same time, new importations are coming all the time. So you have a combination of new viruses being introduced from elsewhere around the world, a bit of local spread. And then, of course, we found that in 2022, in response to this really horrific outbreak, people were changing their sexual behaviors. That's always going to be temporary. So sexual behaviors have moved back to more, baseline typical behavior, and that lets Mpox spread a little bit more. Okay, so one of the frustrating things is we don't really have a perfect single explanation for what's going on in the epidemiology. Is there waning vaccine immunity? We really don't know. We know that antibodies from the 2-dose Jynneos vaccine are gone by a year. But as Dr. Gandhi said, obviously immunity is not gone. And we don't really know what the level of vaccine waning is going to be against disease over time. Obviously, as we move from 2022, vaccines are really not happening anymore. And it's not only about getting the second dose if you haven't had it, but it's also if people are if people are aging into sexual maturity, aging into sexual networks, or entering sexual networks without any vaccine at all, that can have a huge impact on Mpox spread across the entire network. So thinking about younger folks, thinking about folks who might have just come out and talked to them about an Mpox vaccine as they're changing their sexual behaviors. There might be, we don't think there's really viral evolution happening here. We think there are really dynamics happening on the behavioral and immunological sides. Just Andy said all this, so I'm just going to go over it quickly. But in terms of people living with HIV, it is a large proportion of Mpox cases, 40% of cases. But we think that that's largely a network effect of the communities where Mpox is really having an impact. And again, if folks are on HIV treatment, taking that treatment consistently, Mpox is not more severe than in anyone else. But again, we said this in 2022, if we do not get ahead of this virus, it's going to impact the people who are already left behind in HIV. People in the rural South, Black folks, brown folks in America, people without affirming primary care physicians, people without health insurance are going to, this virus sees everyone. Who's going to be impacted the most? The people who are already disproportionately impacted and left behind in the HIV space. And it is a cruel sort of biological fact that in people with untreated HIV, Mpox is incredibly severe and makes HIV therapy initiation really difficult. And sometimes HIV therapy cannot be successfully initiated in folks. And that's where we find Mpox deaths. I will just quickly mention that 3 cases of clade 1b, which is again the strain of Mpox that is largely spreading in Central Africa, were identified in LA County. And this made the news. And why? Because these cases, none of these 3 cases were linked to travel. What this means is that there clearly was a person who traveled to LA County. That case was not captured by testing. That person was not identified, and there was some spread occurring within LA County, again, amongst queer sexual networks. So that's disconcerting because we know we missed something. And that's the first time in the US where we know that we have cases that are not linked directly to travel. Okay, let's talk about the vaccine. All right. The Jynneos vaccine is very efficacious, even against infection, approximations of 75 up to 89%. We don't know what the duration of that efficacy is going to be. We've gotten a lot of questions about boosters. Lab workers who work with Mpox get boosters every 2 years. Data show that folks who have had a childhood smallpox vaccination, when they get their Jynneos Mpox vaccination or smallpox vaccination, their antibody response is much longer. But at the same time, there are currently no clinical trials that are actually testing with a control group booster efficacy. So there are some trials, small trials out there looking at the immune response, but efficacy, no. And the FDA had long signaled that they would need that type of a trial in order to approve a booster. Now the FDA is a disaster. It's very difficult to predict what's going on there. But really, to show booster efficacy, we need to mount the type of trial that can measure efficacy. And that is, as of now, not occurring anywhere around the world. What this means is that we are far away from access to boosters. So if we do see a continued increase in cases, like Dr. Gandhi said, we don't have an antiviral, which we thought we did in 2022. And we can't just tell people to go out and get vaccinated, because if people are fully vaccinated, there's no booster. So we're actually, in many ways, in a worse place than we were in 2022. It's very important to note that Mpox severity after vaccination is much lower. Now, this is good because people are not suffering in the way that they did when they were unvaccinated in 2022. This actually, in some ways, makes Mpox more difficult because cases, we think, may even be subclinical or may be difficult to call Mpox and not herpes or a syphilitic lesion or something else, where a clinician or a patient might not have Mpox on their radar. The person hasn't traveled. The lesion sort of resolves itself within a week and everyone goes on, but that is sort of a missed piece of information, and that person might have transmitted Mpox to others during that time. Okay. I really want to end once again with this notion of leaving behind the already left behind, both domestically and globally. I've talked really about the US, but as Dr. Gandhi said, we are constantly leaving behind people in Central Africa. There's still very little access to vaccine in that context. We won't have boosters in the US context. Folks who are not able to access HIV treatment and prevention are certainly, going to have a hard time accessing Mpox vaccine. And the more we have barriers at the federal and local levels to care for HIV and Mpox, the more we are leaving people at risk of severe Mpox and even death. So really, it is all of our obligation to care for everyone as best as we can in order to prevent the outcomes for those who have had vaccine and those who haven't. And I would love to open it up to questions at this point.
Thank you so very much, Joe. That was really well timed and understanding of what we're dealing with right now, and also connecting both our domestic response, also to the global response. I want to thank Monica, Andy, and Joe all for their presentations and opening up the space. We are opening it up to questions at this time. You can either put your questions in the chat, or if folks want to come off mute and put them, but we know that folks have already started to put some in the chat. I know there was a question earlier about the newsletter, and there was access to many pieces around the website. The first one, so do we know if a delayed second dose is as effective as a timely one? As one question, and then I also see this question for Monica. Do you think that clade 1 likely to be a more difficult and more serious infection compared to clade 2 in Western care settings?
I answered the first one in the chat. The answer for efficacy is there's no trial on efficacy, so it's hard to say. But a delayed second dose, if you believe that antibodies correlate somehow to efficacy, actually delaying second dose leads to a longer duration of the antibody response. So it is not a problem to have a delayed second dose, and indeed may lead to somewhat longer lasting efficacy if the antibodies are to be believed.
Yeah, I mean, I would just mention on that, Stanley Plotkin has always talked about this, that we actually do need to space out doses of all vaccines. It is better for boosters or the second dose to be given later. Actually, this was true of COVID as well, and the 3-week, 4-week duration was too short with the Pfizer and Moderna respectively. So it is always good to have a little more space because that's how you make your cellular mediated immunity. And in terms of this more serious infection, I think this is such a good question because, there was the lore that clade 1 is 10% mortality, very severe. The problem is that, again, we didn't give vaccines and we didn't give global vaccine equity, and also care is different. When you get your first infection and you're totally not immune, just like with COVID, you can get sick. And so it really was around supportive care. And when I just mentioned that DRC trial at the end of tecovirimat, people were quite sick, but they got hospitalized, they got supportive care, and they did just as well as people do with clade 2. So it really is, the issue is that anything that has severe disease needs a vaccine. It's why we developed a vaccine for SARS-CoV-2 and we didn't develop a vaccine for the common cold. And Mpox can give you a severe disease at the beginning. So we need a vaccine. And then by the time you get to your second dose, you're definitely less likely to have not severe disease. And then, as Andy said, we got to treat HIV if you're living with HIV.
That's the only other
And I
thing that
see
I
this
would add.
ACTG question. Yeah.
The only thing I would add to what's being said by the others is, as I said in my presentation, SAGE will be considering some of these questions about vaccine doses, etc. And I think for me and for others that have been part of the response, but also personally kind of like impacted, I think there are also questions about people who've had confirmed or suspected infection. What are the what do we need to do vis-a-vis vaccines for that cohort? So I think there are some really important questions for our community. Yeah.
Yeah, and I'll just hop on that. The frustration that I have as a scientist and community member is that these questions are not being asked and answered. What is the duration of immunity post infection? Not only do we not know, but there's no study on it. There's no robust study on it. And, when I was in 2022, ICAP at Columbia did a webinar, and someone from the DRC had a patient they had treated who had Mpox 3 times in 5 years. This is obviously an outlier. That is not common. It was a healthcare worker who has a lot of exposure, but these questions could be asked, and they are not being asked in a robust way. And so we're going to continue to have to sort of do the best we can to message imperfect information.
And in terms of the ACTG, we have mentioned a lot about the disruptions in care and what's happened with funding cuts with the CDC, but obviously there have been terrible funding cuts and terrible disruption of NIH-funded research as well, and that includes the ACTG, which is why it's hard for them to do something like this right now.
I see we have a couple hands. First, we can start with Lorenzo.
Oh, I just wanted to ask, you guys use, and nomenclature for me is very important, and you guys use the term interchangeably, sexually transmitted disease, and then some people say sexually transmitted infection. So I think that when you're talking to community, we need to be very clear on the language. And my question is about the preparedness now. What do we do since the administration has destroyed the preparedness offices, and we're not sure who's accountable for what? What do we do with this with monkeypox? And not only that, New York, for example, I live in New York City, and when they gave the shot, they only gave 1 shot, and they never called you back for the second shot. So that's kind of interesting that this is now creeping back up. So can someone comment to that? And Monica, Could you comment on the OI, the opportunistic infection? Because again, that goes back to sexually transmitted disease versus infection.
I mean, it's just like Andy said, it's really untreated HIV with low CD4 cell counts where the disease is more severe. We didn't actually see it in that first 528 person series from the New England Journal first described because 98% were treated. Everyone was treated, and then we saw later that it's with low CD4 cell counts. And whenever we see anything with low CD4 cell counts and more severe disease, then we classify that as an OI. And so treating, of course, HIV is really important. And you're right, we're in also an era of what's happening with disruptions in PEPFAR, which is terrible. But sorry, your second, oh, STD, I mean, it really is, there was actually a lot of issues at the beginning classifying it as an STD, and I'm not sure why, but I think it feels like classifying it as an STD just because there are other non-sexual routes of transmission still seems prudent to me because then you can get the Mpox vaccination into STD clinics. Municipal city clinics can have the ability to test. It's a good idea to have care classified with the general mode of infection, even though it's not always an STD, but it is mostly an STD.
Joe, did you want to add? Lorenzo, thank you. No, thank you for that question. It definitely was useful, and thank you, Monica, for answering. The next hand I see up is Emily.
Thanks so much. And this is thank you to all the speakers. And this is building on Lorenzo's question a bit, but in turn, can folks reflect on sort of what preparedness looks like now, given the sort of destruction of the CDC? Like, quite frankly, like where can people get vaccines? If you are or underinsured, where do you get vaccines? What communities geographically are we thinking about? Same thing with testing, like just to sort of, and I know this is a huge question, but like in the current public health environment in the US, what should we be as a community? What should we be flagging as warning signs, and what should we be worried about and happy about if there's anything? I'd love good news. Love it.
I can pop in there. There's good news and bad news. I mean, the good news is, for example, LA County is doing incredible surveillance. That's why they found Clade 1 first. It's not because Clade 1 went there first. It's because they are the best in the country at surveillance. The testing landscape for people with insurance is pretty good right now. It's not like in 2022. Anyone can walk into a CityMD or urgent care and get an Mpox test and get it sent out. LA County is incredible because they have this thing set up where they're doing full genome sequencing, even for people who get tested privately. So they're getting this stuff up in 2 weeks after a swab. I mean, it is unbelievable. So the lay of the land is that the feds have completely, taken themselves away from all of this work. So everything is about the city and state where you live. If you're in LA County, they rock. If you're in New York, it's okay. If you're in the rural South, frankly, you're fucked. That is the lay of the land, and it sits on top of the disparities that have impacted every health emergency and day to day for decades in this fucking country. So, it is sort of without the feds, even with the feds, that was the case. Without the feds, it's even worse. Vaccination, if you're in New York or LA, you can go into your public health clinic, no questions asked, get a free vaccine, not a problem. If you're in Atlanta, yesterday on the pre-call, I went to Fulton County, clicked on the find a vaccine in Atlanta, and it brings you to a broken CDC webpage. That's Atlanta. That's not the rural South, right? So we have a lot of work to do around geographic disparities, around issues of access to healthcare. The people who want the booster are not the people I'm worried about. If they get Mpox, they're going to do fine. The people I'm worried about are the people where this isn't on their radar. We don't have access to information to get out to them. So it really is sitting on top of the disparities for HIV and every other thing in this country. And it's very frustrating.
Joe, thank you for your transparent answer, your honesty there. And that definitely was something that we definitely t did touch base on the prep call. The people have and also Andy is as some of the folks have also talked about, like who have, never tested for HIV, for example, and there are definitely like huge swaths of people that are missing some of this. And I can definitely, as a person living in the South, I also understand these disparities. Um, sorry, I see Jeremiah's hand. We'll go ahead to Jeremiah. I also see there's some things coming in the chat that we will bring up right after.
Thanks, Max. Jeremiah Johnson, Executive Director at PrEP4All. I'm just incredibly grateful to all the speakers for showing up today. I think the breadth and depth of the questions in the chat go to show why we wanted to have this discussion, because I think there's a lot of quiet anxiety about the Clade 1b news, about news of increasing cases. But precisely why we wanted to have this conversation is because one, we don't want people to freak out. I think you've made a clear case that we don't know what all of this means. We don't know, it really has reinforced the importance of helping us to get vaccine to those who have not been vaccinated. But the thing that we wanted to point out for people is exactly what all of you have said, which is, in many ways, we're less prepared. If there is a resurgence, if there is more severity because of what we've seen in terms of the transformation of the public health space. And I will just say, in terms of the conversation of, how prepared we are, we've reached out to some of our contacts who were our contacts during 2022 to see, do we still have allies in the federal government? We don't. It's just not there. So, Joe and I, we reached out to New York City Department of Health and Mental Hygiene, and working with those cities is going to be an important touch point. I think we want to explore what's the advocacy response here. Do we reach out to the new governor's Public Health Alliance? What are we going to have to do? I've been doing some poking around to see what is Bavarian Nordic, the manufacturer for the Jynneos vaccine, doing right now. They seem to be largely MIA, quite frankly. And so I think there's advocacy to be done there. And so, I want us to get to some more of the questions. And if we don't get to it all here, we'll download them and hopefully be able to follow up with everybody so that we can get to all of it. But I just wanted to bring this main point here, which is this is just to get us sort of linked and informed, sort of prime the pump a bit. Because if there's going to need to be more of a response, we're going to have to really rev it up because we're just not in a great situation around it. But hopefully it's not going to turn into something, that is as concerning, as it could be. One thing I will just highlight is I do know that Scott Bertani is on here from Health HIV. I know that you guys have a funding opportunity for people to do community education around Mpox. That's another problem, is that this advocacy is unfunded most of the time right now. We don't have funders for it. So I know you guys wanted to lift that up, and if you want to put that in the chat, by all means, feel free. So thanks for indulging my rant there for a moment.
Thank you, Jeremiah.
Thank you, Jeremiah. Thank you for breaking that down. I did see Ben's hand.
Oh, I was just going to talk about that very same application there. So we'll put that link in the chat.
Thank you so very much, Ben. And thank you for bringing that up. I did see there was a questions, particularly on like what would it needed to be to build a study around this, and I know that's a lot for our panelists to try to answer, but what is needed in some of the responses to this, as also thinking of like as a last word for each of y'all as we closed out the call, about kind of like what is needed in the response and what do you feel like would be some of the most important next steps for folks in addressing Mpox. And can start with Monica.
I think awareness and not being worried about classifying something as an STD. We have now DoxyPEP, we have Mpox vaccination, we have HPV vaccination. Like and we're going to get it a chlamydia vaccine, gonorrhea vaccine, I hope like we just like STDs just spread like anything else. Like we have to just have the procedures for controlling STDs. And of course, we need this administration to change because this administration is a disaster for infectious disease and public health. It needs to change. We need to all be really, really active as advocates. This has been a terrible time.
I think I pointed to the fact that at the forefront of knowledge, we're not doing the studies necessary. We're not doing a clinical trial about booster doses. There's a lot of unanswered questions about severity of different clades. There's a lot of unanswered questions about if household transmission leads to the same outcomes and it has the same vaccine efficacy as sexual transmission. So science is just not being funded and it's not being done. And that was a problem before Trump. And that's going to continue to be a problem because this is viewed as a disease of Africa and faggots. And we know what those outcomes are in terms of research on diseases that impact, those communities. That's number one. Number two, who have we always left behind and who's getting left behind already? You can do all the fucking booster studies you want, but there are people out there who haven't had access to one vaccine. And 70% of our cases in the US continue to be in people who have had no vaccine. So science is necessary, but not enough.
Jumping in after Joe, I know we're short of time. Just to say, I think I really like when Monica really started with this idea of global solidarity around the lack of vaccine access in parts of Africa. And I think bringing the global perspective, I think I'd just like to, bring us back to that point, really. I think we do need to maintain global solidarity. Building on Joe's point, we need to all constantly be thinking about who's being missed out, who are we leaving behind. We need to see this as an opportunity to fix what's not working in HIV. As well, because that's such a vulnerable point for all of us. And then just to say, I think that as all of you in the US struggle with your changing architecture and environment, obviously the same thing is happening around the world. So I think we saw some fantastic collaboration and solidarity during the first public health emergency, and let's try and get that spirit back. Thanks.
Thank you, Andy.
Yeah. Thank you to all of our panelists. Thank you all so very much. Thank you all for joining us for this conversation today. This is important to be able to have these updates. Please email directly questions and follow-up that you have to Michael, who's helped make it all this happen and setting up this webinar. So one shout out to you. Please follow up with him if you have questions or comments, and sign up for our PrEP4All that Jeremiah dropped in the website to make sure that folks have that. Thank you all also very much for joining us. And we will follow up with more information on the Mpox response as we're also fighting for HIV funding and many other spaces here. But know that we'll continue to keep people connected around this, and thank y'all.
Thank you.
Thanks all.